Hi, this is Dr. Mitch Strominger, and I'm actually a pediatric ophthalmologist here at Reno, Nevada and University of Nevada School of Medicine. And it's really a pleasure for me to kick off the AACO meeting. As you know, I love the orthoptists, and I wish I could see you all in person this year. I miss hanging out with all of you, going to the president's reception and dancing up a storm, although I'm getting a little older for that. Anyway, I wanted to talk to you today about the utility of OCT ganglion cell measurements in visual pathways disorders. And although I'm a pediatric ophthalmologist, I also do neuro-ophthalmology. And a lot of the orthoptists work with neuro-ophthalmologists. And out here in Reno, I actually practice a lot of neuro-ophthalmology. And I use the OCT on almost every patient now. And I just wanted to talk to you about some new ways we're looking at OCT measurements. So I wanted to start off with a case. This is a 60-year-old man with high blood pressure and had sudden onset of headache, right-sided hemianopia, right hemiparesis, right paresthesia, and aphasia upon awakening. So, there was no doubt here that he had a stroke. And he had his MRI scan revealed that he had a left posterior cerebral artery territory infarct and a thalamic infarct. And he was sent to me because of problems with his vision. He was outside the TPA window, so he really didn't get much treatment other than started an aspirin a day and Plavix and statins. His workup for a stroke was pretty much unremarkable. His cardiac echo was normal. His cervical MRA was normal. He was admitted to rehab, and when they realized that he was having some trouble with his vision, he was sent to neuro-ophthalmology 3 months after the stroke. So his vision actually was great. Now, it was 20/20 in both eyes. There was no afferent pupillary defect. His color vision was full, as well as motility, and his discs were pink. But as you can imagine, with the posterior cerebral artery infarct, he had a visual field defect. And you can see in the left eye, it was a right field defect, and the right eye was a right field defect. So he had a right homonymous hemianopsia. And that goes along with this stroke lesion and the left visual pathways extending into the region of the occipital cortex. So, this is pretty standard that everyone sees who sees patients with strokes. Here is his OCT, which we did. And his OCT, as you would expect, the nerve fiber layer was completely normal. And that was in the right eye and in the left eye. And on examination of the optic nerves, he did have some tilting with some peripapillary change, but there wasn't really any significant atrophy in either eye. But the surprising thing is nowadays we're doing this thing called the ganglion cell analysis, and you get this off your macular OCT. So you have the patient look into the camera or into the OCT machine, and you see the macula. You can actually look at the ganglion cell. And interestingly enough, what we're finding in this patient especially is you can see on this right slide of the ganglion cell analysis that he definitely had decrease in his ganglion cells in the right eye and in the left eye. And so the right eye was nasal and the left eye was temporal. And this corresponded to that visual field defect that we saw on the MRI scan. So it's kind of surprising because if you think about the way the visual pathways work, you go from the optic nerve to the lateral geniculate body. And if you don't have any injury there, you don't expect any changes in the optic nerve itself. And so here's sort of the pathways that we're talking about. Your ganglion cells start out in the retina, the upper layers, and send their axons then through the optic nerve. And in the diagram on the right, then it sends it to the lateral geniculate body, where it then synapses and sends projections to the occipital cortex. And we were always taught that, if you have a lesion somewhere between the retina and the lateral geniculate body, you would see atrophy and changes in the nerve. But if you had lesions from the lateral geniculate body more posterior to the posterior visual pathways, the optic nerve actually should be normal. And certainly on his retinal nerve fiber layer and looking at the nerves, they were normal as well. But the ganglion cells were off in that projection. And they corresponded very well to his visual field defect. So let's talk a little bit about OCT and retinal nerve fiber layer. I don't want to spend a lot of time on this, but the retinal nerve fiber layer takes this circumpapillary OCT ultrasound images of the nerve fiber layer thickness, and it actually analyzes the axonal portion without considering the cell bodies, which are the retinal ganglion cell bodies, and the dendrites that reside in the ganglion cell layer and in their plexiform layer, respectively. So in this patient, the axons had normal thickness. But if you look at the OCT in the macular complex, most of the retina guys are looking for lesions in this area and whether there's thickening, but you can actually ask the machine to look at the ganglion cell layer, which is from the internal limiting membrane to the outer, and there's the thickness of the ganglion cell layers, and you can actually analyze those layers and get a measurement. And that's what we're doing when we're looking at the ganglion cell complex on the macular OCT. So what are we seeing? We're seeing this retrograde axonal degeneration, and it was theorized that why are we seeing this change? And we see it because there's a loss of trophic support for the injured cell to the presynaptic dendritic tree. And the thing about it is we don't see this with all posterior lateral geniculate lesions. So not all patients with posterior strokes show changes in the ganglion cell layer, but there's certainly patients that we do see it in, as in this example. So what do we have to consider then with these posterior lateral geniculate lesions? You know, this was great because if the Humphrey visual field was not available, the ganglion cell complex detected some of the posterior lateral geniculate lesions, and that's the case. Doesn't substitute for the Humphrey visual field, but if all of a sudden you just can't get a visual field and the ganglion cell complex can be performed to the OCT shows changes, well, then you have to be really concerned that there's something going on, and then maybe follow up with the Humphrey visual field. I tend to do both, although on occasion, if I'm in a rush or we don't have the Humphrey available at that time, definitely going to look at the ganglion cell complex. The other question in my mind is, you know, does the extent of the lesion or the chronicity of the lesion affect retrograde axonal degeneration to the point of being detected on the OCT? And we just don't know the answer to that. So, you know, maybe we're seeing it in people who have larger strokes or people whose strokes are more dense, or maybe you might not see it on the initial stroke, but as time goes on, then you can see the retrograde axonal degeneration. So we don't know the answer to that yet, but it's an interesting thing that might come up. The next patient is a 24-year-old man with a suprasellar lesion. He noticed decrease in his peripheral vision, and his visual acuity was 20/30 in the right eye and 20/20 in the left eye. His color vision was normal. There was no afferent pupillary defect, but he was sent to me because of the size of the suprasellar lesion and to look at the function of the optic nerve. So this is, you know, another typical common consultation that we might get in neuro-ophthalmology. And you see that in the right eye, yeah, I think there's a little pallor. You know, there may be pallor in this region to the optic nerve. And in the left eye, maybe some subtle pallor. It's hard to know for sure. And then we look at the MRI scan, and that lesion is huge, right? There's no doubt that it's big, it's suprasellar, it has sort of a cystic component up here. There's enhancement around the edge. And the other thing you see is there's definitely splaying of the optic nerve in that area. You can't even see the optic nerve on the right side. On the left side, it's sort of splayed out. So you'd expect us to see some sort of visual field problem. And sure enough, here's his visual fields. And you can see on the right side, there's a dense right field defect. And on the left, there's a hint of a defect here. Actually, it's not a hint. There is a defect there. It's just not as large as on the right side. And so this is showing that he has an incongruous or asymmetric bitemporal defect, which is what you would expect from where the lesion is located and how it's playing the optic nerves. And here's his retinal nerve fiber layer analysis, as well as the ganglion cell analysis. And you see there's definitely asymmetry in terms of the overall thickness, although it's on average, it's actually still within the normal range. So in the right eye, the average was 84, in the left eye, 104. We sort of expect that given the fact that we can't even find the optic nerve on the right side. And if you look at the quadrantic representation, you do see that nasally, there is a decrease in the retinal nerve fiber layer thickness to 54. And so that definitely would go along with his temporal defect. But interestingly enough, in the left eye, where he definitely had a defect, but it wasn't as large, his OCT retinal nerve fiber layer actually looked pretty good. So if you were just looking at this scan here and trying to determine whether you wanted to scan someone for a possible optic nerve issue, you may say, well, shoot, that nerve looks pretty good. What's the chance of him having a compressive lesion? And when you look at the ganglion cell complex, you can also see that there's no doubt that there's nasal depression of his ganglion cell on the right eye, and the left eye is actually pretty normal. And this corresponds, the ganglion cell decrease certainly corresponds with that larger right visual field defect temporally, as well as corresponds to that nasal decrease in the retinal nerve fiber layer thickness. So, the question is what do we know about these suprasellar lesions? Well, we do know that following surgical decompression of suprasellar masses, there's often a dramatic recovery of vision, especially with adenomas. And when I was a fellow, we were always taught that if you decompress the nerve and it didn't get any better, well, you wanted to make sure that nothing else was going on. Sometimes fat packing would be left in. So we'd expect that with decompression, there should be some improvement. And the reason why is probably it's not compression of the nerve by the lesion, but actually due to ischemia as the blood vessels are being stretched by the mass. And here's a diagram of the perfusion of the chiasm. And you can see the chiasm actually is perfused by superficial chiasmal arteries off the anterior cerebral artery. There's branches of the ophthalmic artery that perfuse the chiasm, and also branches off the hypophyseal artery into the chiasm. And the thinking is that as these tumors enlarge, it's not just the tumor pressing on the nerve causing damage, but what's actually happening is that that's stretching those blood vessels, so you're getting some ischemia to the nerve that can be reversible, depending upon how long the ischemia has been there and as long as it hasn't caused an infarction of the nerve. So the interesting thing now about these OCTs and kind of corresponding that retinal nerve fiber layer and the ganglion cell layer to the visual field is, can we predict whether there's going to be recovery of visual field function after decompression of suprasellar masses? And is that dependent upon the OCT retinal nerve fiber layer, the ganglion cell layer? So in this case, that left eye definitely showed a visual field defect. There's no doubt about that. But the retinal nerve fiber layer and the ganglion cell layer was normal. So is there a higher likelihood of recovery of function post-decompression in that left eye where the retinal nerve fiber layer and the ganglion cell layer was normal, if you decompress soon before you actually might get an infarction to the nerve in that area? And then the question would be say what happens if the ganglion cell layer was decreased, but the retinal nerve fiber layer was pretty normal? Is that at all predictive? So if the ganglion cell layer was decreased, well, maybe even though the retinal nerve fiber layer is normal, then that may portend a poor prognosis when decompression. So we don't know the answer to that, and these are all interesting questions that have come up now that we can compare our OCT retinal nerve fiber layer and ganglion cell layer to her visual field. The next case I wanted to talk to you about is a 26-year-old woman who has a history of multiple sclerosis. We know she has a history of multiple sclerosis. There's no doubt about that. She was referred by neurology, though, because she had these episodes of episodic blurry vision for 15 months in the left eye. And her vision gets blurry when she's stressed or with overexertion, and then improves to baseline. MS was diagnosed in 2015, so the patient presented to me in 2021. And it presented with an episode of left-sided weakness and sensory disturbance that improved. And her MRI scans at that time had showed multiple MRIs confirming the diagnosis with non-enhancing white matter lesions. So here's her examination. Shows she's 20/20 in the right eye and 20/20 in the left eye without correction. Her vision was completely normal. There was no afferent pupillary defect. Her nerves appeared pink, and her Humphrey visual field appeared full. And you can see the nerves actually really look pretty good. The photo on the left is just a little bit blurry, but there wasn't really any appreciable atrophy or anything like that going on. And her color vision was good, as well as she didn't have an APD. So, she was sent in for episodic blurry vision, but you would say, boy, you know what, everything actually looks pretty good. So maybe she does not have an optic neuropathy from MS. Here's her OCT. And the OCT, as you can see in the right eye, her average thickness was 94. But in the left, interestingly enough, her retinal nerve fiber layer was a little decreased. So there was an asymmetry to that. And then if you look at the quadrantic representation, you see that actually there was a decrease in her temporal retinal nerve fiber layer. So this is sort of a little bit unexpected because, her vision's good. She has no APD and her color vision's good. And then when you look at the ganglion cell layer, boy, it's really striking how much lower the ganglion cell complex is on that left eye and the right eye, and especially in that area corresponding to the temporal fibers, which would indicate more of central macular projections. So in this case, both the retinal nerve fiber layer and the ganglion cell OCT demonstrated decrease in the left eye. So the thinking is that, wow, this patient actually probably had a subclinical episode of optic neuritis. She never knew she had it. There may have been never an episode that she knew her vision was decreased, but she certainly has loss of ganglion cells and retinal nerve fiber layer in that eye. And so when you sort of put this together with her intermittent episodes of blurry vision, we asked her more questions about when it occurred, and it tended to occur more when she was tired or overheated or exhausted. And it was thought that she had an UTOF phenomenon. And for those of you who might not know a lot about UTOF phenomenon, it's this transient worsening of neurological function lasting less than 24 hours that can occur in multiple sclerosis patients due to increase in core body temperature. And it was described in the 1890s, and it was, interestingly enough, from our standpoint, it was quoted as exercise-induced amblyopia in multiple sclerosis because it was transient. But later was understood as the rise in core body temperature. In the 1950s, they knew a lot about this and actually would help try and secure a diagnosis of MS by putting patients in a hot bath test and see whether that changed their neurological symptoms. And if it did, that was consistent with demyelinating disease. And if you actually do nerve conduction studies, there's a decrease in neural conduction velocity in response to this increase in temperature. So this brings up a couple interesting things about doing OCTs in patients with demyelinating diseases, because now we're seeing that patients can have subclinical evidence of optic nerve dysfunction on OCT, retinal nerve and nerve fiber layer and ganglion cell layer thickness. And patients who have known retrobulbar optic neuritis in clinical recovery, so we have patients who had optic neuritis, we knew that they recovered clinically completely back to normal color vision, no APD, still can show changes in the OCT ganglion cell layer. And the other thing is patients who have transient neurological defects that resolve and no known episodes of optic neuritis, even with a normal MRI scan. So if you have a patient come in and say, hey, you know what, I had this episode where maybe my arm was numb for maybe a week or two, or I just couldn't seem to have strength for a week or two, and have MRI scans, and you're scratching your head, or the neurologists are and saying, hey, you know what, can this patient have MS? And they do the MRI scan, it's completely normal. If you have changes in the OCT and ganglion cell layer that are consistent with a past optic neuritis, this may help secure a diagnosis of demyelinating disease in those patients. So what's the conclusion for all this? Well, we can say that retinal nerve fiber layer OCT and ganglion cell layer is a powerful tool looking at visual pathway disorders. We can now demonstrate evidence of retrograde axonal degeneration that's now possible when we never really thought it even occurred. We can say that retinal nerve fiber layer and ganglion cell layer might have a role in predicting visual recovery, especially in cases of compressive optic neuropathy. Like in our case, if the visual field defect was there, but the OCT, retinal nerve fiber layer and ganglion cell was normal, can you say, wow, if you decompress this patient, there's a higher likelihood of recovery? And that OCT ganglion cell can demonstrate subclinical episodes in demyelinating disease and can help support the extensive disease burden or even the diagnosis. And finally, OCT ganglion cell layer is very easy to obtain. You just need to ask your photographers or whoever does the testing. And now it's become sort of standard in my clinic where we're looking at the OCT retinal nerve fiber layer in all the patients, and they just switch it over to the macular scan. It takes less than a second, and they do the macular thickness test, and then you can select the ganglion cell complex. And I think this is really revolutionizing how we think about some patients and giving us a lot of data that hopefully will allow us to provide better patient care. So thank you very much for your time.